And welcome to another At Lunch webinar with Azalea Health. In this edition, we're going to review the results of the 2015 Rural Health IT Strategy Survey. Please keep in mind that we are going to record this webinar and post it on the Azalea Health website. You can view that at www.azaleahealth.com under News and Events and Webinars. My name is Justin Pierce. I'm the VP of Sales for Azalea Health. And with me today, I have two panelists and experts in the industry, Justin Barnes and Baha Zeidan. Justin is Industry and Public Policy Advisor, Chairman Emeritus HIMSS EHR, Co-Chairman Accountable Care Community of Practice, and he's addressed Congress many times on a variety of healthcare-related topics. Baha Zeidan is the CEO and founder of Azalea Health. And good morning, guys.
Good morning.
All right.
Great to be here.
Happy to have you. So we have a great result coming back from this survey, and I want to review a couple of the findings from the survey itself. We're also going to talk about health IT use in today's agenda, barriers, revenue cycle performance, challenges, ICD-10 readiness, meaningful use, and questions can be held toward the end here. So please submit them throughout the webinar. There is a section on the GoToWebinar that you can submit, and we will draw them up, and if we have time, Baha and Justin will respond to them. All right, so the scope of the survey, I think Baha can kind of review it. It was sponsored by Azalea Health.
Thank you, Justin Pierce, and I'm truly honored to be with Justin Barnes to discuss the survey, and we're very excited to focus on the rural market on this survey. Azalea Health started in rural Georgia, in Valdosta, Georgia, and part of our company culture has been to focus and tailor our products and services around the rural market. The rural market has been underserved, and some of the examples that we see, urban areas, the physicians in urban areas, they suffer from high turnover. In rural market, physician offices suffer from lack of talent and lack of workforce. So we wanted to highlight that. This survey has been administered in February of this year, so somewhat fresh. And we polled basically healthcare providers, nurses, nurse practitioners, physicians, and staff. So we're glad to put the light on this industry for the rural market.
Okay, great. So let's go through some of the key findings. A lot of really great information came out of this experience, and one of the first things I want to highlight is the use of IT and health IT and healthcare. So it looks like the majority of our respondents use an EHR, which incorporates the clinical, financial, and administrative solutions for practices. And Baha, what do you feel about this high level of adoption of HIT?
It's straight on line with what we see as a vendor of health IT. We feel still there, about 60 to 65% of physician offices in the rural market has adopted somewhat of some form of health IT or electronic health record. Some urban areas are a little bit ahead of the game and probably in the 75%, but this is straight on line with what we're finding as a vendor.
Okay. Justin, how do you feel? I mean, it's obvious that most providers, according to the findings here, rely on health IT, in some aspect for their practice.
Yeah, I think it's a great question. I think it's important. First of all, the findings positive from a standpoint of the health IT and EHR use. As you're going to see, and certainly we're going to talk about today, health IT is a core cornerstone to being paid tomorrow in healthcare. It's part of efficiency of practices. Looking for the right partners, also critically important. It's not all health IT brings great intrinsic value. It's looking for the right partner in navigating the future of healthcare together with the use of health IT, with the use of best practices. And I think that's a lot of what we flushed out here in this survey. So looking forward to discussing it in further detail.
Great. Well, I mean, there's not 100% adoption. So you'll see, in this question, we really address that. What are the barriers to preventing practices from upgrading or adopting health IT? And overwhelmingly, the top response was cost. So, Justin, why do you think that cost is such a barrier? How does that come about?
Yeah, no, it's a good point. So I've seen, just being out there for a couple decades now, I see cost certainly as the main barrier in most aspects, and it's brought on by a multitude of factors. Their physicians and hospitals are getting pushed and pinched in every corner, and so they're trying to look for more efficient ways to operate their practices, and also where they can cut back. And certainly when you have outlays of capital for health IT, it can be difficult. And so I think looking again back to the right partner to navigate this, and also they've seen the lowball these companies come in there, lowball them, but then after year 2, 3, and 4, the costs go way up, and then the ROI, return on investment for these systems, health IT, and specifically EHRs, seem to wane. And so I think being very focused on finding the right partner to navigate, whether it's health IT adoption, specifically EHR use, ICD-10, these new models of care that we're going to talk about today, accountable care, that right partner, and then looking at it at a good 3-year projection, so where the partner's going to come in at, and they're not going to jack up these costs come years 2, 3, and 4 like we've seen out there. And so again, that's why they're skittish on costs, and it's always a main point for them.
And as far as the cost, I wanted to add, many of the physicians feel that one of the aspects of the cost is slowing them down, where maybe they will have to see less patients for a few weeks, right, for 5 weeks, in addition to the cost of the EHR, and that's a huge barrier because they have pressure on reimbursements anyways, and when they see less patients as they implement an onboard and EMR, it's the hidden cost of the operation is still tremendous as well.
Right. Well, it's a well-known way of controlling costs, outsourcing different components of your operation. And so one of the things that we wanted to learn more about is how it relates to revenue cycle performance. So here you'll see the majority of respondents, well, they actually outsource billing for a variety of reasons, but most often the key driver was to reduce staffing and training costs. So Justin, what do you see as the current situation with revenue cycle, maybe the future of revenue cycle, and how that is being employed as a cost-saving measure for practices?
Yeah, I actually think what you're finding here is spot on. The key driver is reduced staffing and training costs, but I think those are the reasons today, which are strong and terrific, but the reason tomorrow really is going to be around accountable care, value-based medicine, navigating these new care and payment models that are coming out. The president just signed the bill that went through Congress, so that's going to bring on a lot of change in 3 to 4 years from now on how all physicians are paid. And the hospital side has already gone through a lot of those changes, and they'll continue on down those paths as well. So you're going to see revenue cycle management, and you actually said the term revenue cycle performance, become a real key component and a key strategy for practices looking to not just survive, but thrive through the next 12 to 18 months. So I really see this shifting over into optimizing their revenue cycle opportunity and looking for the right partners there.
Absolutely, and with many of the physicians' offices and healthcare providers, hospitals, and providers in general, just like Justin mentioned, revenue cycle performance is very important. Physicians and healthcare providers now, they really need to understand that, how efficient is the operation that is running their practice. There's a lot of more pressure from insurance companies to pay less, to introduce more prior authorizations, and do more to give less. And physicians need to be aware, and healthcare providers in general need to be aware about days in AR, insurance aging, any of the reimbursement analysis that their revenue cycle performance provide to them. So it's a key to dig deeper. Another thing is, as we see in the future, we're going to see cuts that for the health ITs or the healthcare providers, they do not use certified products.
Yes.
And we're going to see reimbursement increases for providers who use meaningful use certified products, and less and more cuts in the pipeline for the ones who don't use electronic health record and certified electronic health record products.
Well, I find it interesting. I like the term performance because it really relates back to another top response that we saw here when it talked about improving office efficiency. So, how is outsourcing your billing going to improve office efficiency? What capacities do we take over that help a practice or a hospital operate in a more efficient manner?
Sure. Well, one of the things we hope to improve the efficiency is by providing a second opinion. Billing, revenue cycle management, and revenue cycle performance companies, they look at the business from a little bit higher perspective when you're inside the business, inside the physician office. So we can look at other best practices in the industry and introduce it to a smaller physician office where they can't see that in the industry. So that's one. The other thing, where we could compare, or a good revenue cycle performance partner can compare the output and the office efficiency compared to the industry standards, right, and what's out there in the marketplace. And that's very, very important, because one thing, as a technologist, we feel technology should bring in efficiencies. That's what but we've seen it many times where technology bogs down offices, and actually we've seen physician offices almost file for bankruptcy because they utilize systems that bog them down. And I'm sure, Justin, you've seen that before.
Yeah, very true.
So it's important that I think in revenue cycle performance and revenue cycle management, you got a different set of eyes looking at you from the outside, and it's important to look over.
Very good point.
All right. Well, let's go on to a higher level topic. We're looking at specific barriers to adoption of health IT. Now we're going to just talk about general challenges. What challenges did the respondents feel they are currently facing and expecting to continue facing throughout 2015? And the top response was declining reimbursements. But there's many different things going on in healthcare right now that affect a variety of different things at all levels. So, what about the current environment leads respondents to feel this way, and how are things changing?
I'll take that. So, obviously they're 100% right on the declining reimbursements. And actually when this survey was put out, we didn't have the doc fix, but as of about 10 days ago, we did have the passage of the Medicare Access and CHIP Reauthorization Act of 2015, which is quote unquote the doc fix, which takes away the 17 cuts that doctors had faced over the past 17 years or so regarding Medicare reimbursement. So every single year, the end of the year, all of us would scurry, would go up to Capitol Hill and do our thing to try to protect physician reimbursement and put a patch on the annual cuts, which would become the doc fix every single year. But here, very happy to report that we have a permanent fix. And actually, in a couple of months, doctors will actually receive a 0.5% increase in their reimbursement. So I think that's terrific. Starting in June. But then, and that's for the next 4.5 years, but then also coming in 2019 or 2020, you're going to start to see the new either alternative payment model program, you can participate in that, or the merit-based incentive payment system called MIPS. Again, merit-based incentive payment system called MIPS. Those are the two programs that are going to be rolled out to the ambulatory and the outpatient physicians and care providers. So I think you're going to start to really see a lot of changes, and so these concerns about declining reimbursements can begin to be slowed down because again, reimbursement increases should be coming in or on the way. But the second item here talks about increasing regulatory issues and items, and I think that that's again a valid concern because you're going to continue to see regulation, and the bottom line is because these are this is the biggest item outside of defense on the national budget. So, we're going to, healthcare is a significant cost. I want to say it's up to, 18%
probably.
Well, it's 18% plus of GDP, but you're talking about, you're going to be pushing a $4 trillion expense here. And so we've got to really look at that, and you're going to see regulation continue for sure. So
that's a good point. And also, of course, CMS and with Medicare announced not too long ago that 50% of the payments by 2018 it would be changed to a performance-driven payment rather than transactional-based performance. And we know that's also going to create additional pressure on the reimbursement. So we're going to see a lot of physicians and a lot of actually health institutions thinking outside of the box to make sure they capture the CCM, and we can talk a little bit even more about CCM, continuing care management, or chronic care management, I'm sorry. And with chronic care management, basically Medicare is offering $40 a month per patient for Medicare chronic patient for managing their chronic care condition.
Yep.
And you can manage that in using telephone, telemedicine, and those are the kind of innovations that we're going to see, that if the physician is open-minded and adopting and moving forward with this, they're going to see increases. And the ones who will resist and stay in the traditional claim fashion, sending the regular CMS 1500 claim, by 2018, that's going to almost, going to be 50% of your payments coming through that traditional fashion. So we hear them, and that's right on line. Reimbursement is a big aspect of what we hear from the physicians.
Well, I think also it goes back to having that expert partner, because to navigate these new models, I mean, I know a lot of physicians and care providers on the line are going, oh my gosh, all of our payments are about to shift. Yes, they are about to shift over the next 4 years. But this is when it's a good time to look for the right partner. And I know we'll talk about ICD-10 as well, because that was part of the survey. But make sure you have the right partner to navigate ICD-10, but then also the right partner to navigate these new models of care, whether you want to go down an alternative payment model route or a MIPS-based route, the merit-based incentive program. You want to find the right partner for that.
One of the most growth area that we're also seeing is the need for prior authorizations. There's more and more procedures right now that require the physicians to prior authorize before they perform the surgery or perform the procedure itself. And sometimes physician offices get overwhelmed and they cannot keep up with it. Check with your partner to see if there's a way that you can track that. It could maybe there's a piece of technology that can help you with the growth of the need for prior authorizations.
All right. Well, and this year it is overwhelmingly the biggest topic of conversation with being ICD-10. However, in years prior, and still is an ongoing concern, is improving patient engagement. In fact, that was a top response.
Yeah.
I think from it gets cut off. It's 3 up from the bottom. But you mentioned these alternative payment models, such as CCM, and I believe telemedicine is on the forefront of being something that is seriously considered for reimbursements and improving revenues. What recommendations would you make using these technologies to improve patient engagement? What can we do to assist with that, Justin?
So, first of all, patient engagement is critically important. If you're going for meaningful use, it was part of stage 1. It's certainly part of stage 2. It's one of the core values, core measures for stage 2. Not only on the ambulatory side, but also on the eligible hospital side. So patient engagement is critically important, but also not just because of regulation, but because you've got to get the patient involved in their care. As all these models are shifting, patient engagement, patient education, patient management, and patient activation, all of those are critically important to get them taking their blood pressure, understanding why they're taking medications, getting them to adhere to their prescriptions, but then and to follow their protocols, but then also get them really active in managing their health care, because everybody's going to be paid based on that. You have to, their costs will continue to rise in most cases, but then also physicians will be paid more when they get their patients engaged and when their patient's blood pressure, gets under control, or their diabetes, or whatever it is, their chronic conditions or their conditions in general. Everybody either can save money and or make more money, and I think that's why patient engagement is so critically important.
And just to add to that, kudos to Meaningful Use. It truly made a huge mindset change. I came from the laboratory space before the electronic health record world, and physicians used to be adamant that I do not want my patients to see their own lab results.
Right.
And that was just in 2005 and 2006, and now they want their patients to see their lab results and be engaged to understand what a CP, what their values and their ranges mean to them, and track them. And that is shifting across all of our culture. Now, we're seeing the introduction of mobile apps. All of that is creating a whole lot of the future patient and current patient is a lot more engaged with their condition than just last year's patient. So it's important.
So let me pick up on that, because also, I don't want to lose the fact also out there that a lot of doctors and practices, it's a love-hate relationship with meaningful use. And so I think that, certainly respecting that, but then also hopefully now with these changes on the doc fix that we do have a long-term fix to physician reimbursement and care provider reimbursement. But as Baha said earlier, meaningful use is a fundamental component. Certainly if you're going down the merit-based side, you still have to meaningfully use your EHR, and you still have to have a certified EHR. And if you go down the accountable care side, or the quote-unquote the alternative payment model side, certified EHR is still going to be important, and a lot of those criteria are based off of meaningful use that are already in ACOs and alternative payment models. So it is a necessary quote-unquote evil, but hopefully you'll be able to see more money coming behind meaningful use, not just that initial $44,000 or $64,000 that you got, whether you went for the Medicare and Medicaid side, but you're going to see more money and all payments tied to the quality measures in meaningful use and or meaningful use in general.
Absolutely.
So very important.
All right. So, gentlemen, let's move on to, I think, if it's not on the forefront of your mind, it's definitely in the back of your mind.
It needs to be.
It
It needs to be forefront.
To the forefront, ICD-10 and everything that comes along with it. This question, respondents were pretty much all over the place, but what is the status of your facility on preparing for ICD-10? So we have 30%, we have our plan in place, that's good. 20%, we're relying on vendors and our billing company to assist, so that's important that you have partners. 25%, about halfway there, so 5 months to go. Hopefully the other half will be done. And 16%, we're ready. That's great. That's a bigger chunk than was at this time last year, hopefully. We'll continue to see that grow. The other 16% say, we haven't started, we don't know. This shows that the industry still has a ways to go, especially with those responses, to be ready for October 1st, and why it's important, to pick a good partner for ICD-10 readiness. I think something that we talked about prior. New payment models in the SGR fix that have been approved by Congress, signed by the President, incorporate ICD-10. It's going to cement October 1st as the transition date. So if you're anticipating it's going to be delayed again, I highly, highly doubt that's going to be the case. So, gentlemen, what are your thoughts on ICD-10, the readiness, and things that go along with that?
As I'll start first as the technology company side of the world. Well, to be frank with everybody, last year when it got pushed another year, well, it gave us the opportunity to see, like in the survey, 30% and almost 25% that they're halfway there. They already started last year, so there's a lot of things were in motion. Now, do we think there's going to be pushed another year? Probably not. But the good thing is, technology always simplifies the world problems. So yes, it is over, depending on where you look, how many codes. So they're jumping from 14,000 codes to, 70 or sometimes 100,000 code or over 100,000 ICD-10 codes. But technology should filter, should be able to provide you mappers and ways to simplify that process. And in my mind, 13,000 or 14,000 ICD-10 is still a lot. Anyway,
it's a lot. It was a lot.
It's a lot.
There's a lot more coming up.
But it's a lot more coming up. And if you think about search and how much data Google provides in one simple search, as a result for one simple search, it's possible. So hopefully all the vendors, but the good ones definitely provide those tools to make that transition simpler and easier. And what other things we're seeing? I was actually speaking with an analyst last week that is observing on the hospital space, and one of the things that they're seeing that there's nobody yet spending on ICD-10 because they're waiting, or because they spent it last year, and this is correct. That's the line. But we're going to see a lot more people that waited at the last minute, and hopefully your vendor can accommodate your last minute request. So if you're not ready July, you're definitely late because October 1st is around the corner. Second thing is, Justin Barnes, you were at HIMSS. Did you get any vibes at HIMSS that there's going to be a push another year of ICD-10?
Yeah, I did not. I think that you're going to see ICD-10 come in October 1st this year, and I even believe that the reason why I feel it's fairly cemented at this point is because we just passed the doc fix. So all these new payment models are going to be based off of ICD-10, certainly not ICD-9.
Sure, definitely.
So I don't see any slippage or changes, and I agree with you. You really need to, I'm a little alarmed here by the only 16% ready. I think that's a little scary because that's how practices are paid, and then also hospitals. But I think one thing to look at on the payment side there, a lot of practices don't have 6 to 12 months of revenue in the bank or of payments ready to go if their claims slow down. And that's what very well could happen if you're not ready to process an ICD-10 claim by October 1st. Your claims could be denied, slowed, and that's just scary because a lot of the practices that I visited, they may only have a month and a half of bills that they can pay in the bank. Enough money to cover their bills for about a month and a half, maybe 2 months, 3 months if they're really fortunate. Mm-hmm. So if you're talking about a major hiccup with ICD-10, that would just scare the heck out of me. I know as a provider for my family, if I only had a month and a half of capital in the bank to cover my bills and I was looking at a significant disruption in how I'm paid come October 1st, I'd be worried. And that's just me with my family, never mind all my employees and everything. So nonetheless, I think it's very important to take very seriously. So I would have wanted to see that 16% higher. I would have loved to have seen 16%, closer to 50 to 60%. Sure. But it's understandable. So again, go back, get the right partner. But also, I think you may have mentioned this, Baha, but if you didn't, you've got to partner by July or August at the very latest to be ready for October 1st. You can't just walk into someone, a vendor, and say, hey, in September, I want to be ready by October 1st. It's not going to happen. So you need to go in there, get the right partner, July, August timeframe.
And when we're talking about vendors, when it comes to ICD-10, sometimes it's not one vendor. It's your AHR. If you have a different billing system, it's the billing component of your business. If definitely the clearinghouse, definitely possibly even the guys who handle your patient statement. They may need to make some format in their patient statement. Whatever, you have to look throughout all your vendors, not just one specific vendor, because it's a major task, and it's going to be and like Justin Barnes mentioned, ICD-10 touches everything from from the moment we diagnose a patient all the way until we get paid and reports on what we're doing. ICD-10 is going to be covered in all of that. So it's interesting topic.
Sure. Let's fast forward to October 1st. I feel that we're all optimists in this room. What percentage of the industry do you think is going to be ready?
I've never been asked that question before. That's a good one. Actually, I'm speaking at an analyst conference right after this, and I'm probably going to ask that question. I got to be ready for that. I'm hoping 95 to 100%, but but I'm maybe 85%. I would say. Maybe you're ready.
I don't know if I want to throw a number.
I think you're lying. I'm hoping 95, but maybe only 85.
I think we may have, hiccups in October, but we're gonna, just like that meaningful use adoption. Meaningful use adoption has been fairly quick, or quicker than what I thought.
Yeah.
But something touches the physician pocket if they couldn't make it through October 1st. Definitely by November, December.
Maybe October 2nd, right?
October 2nd.
Well, we know all of Azalea Health customers will take it.
Well, thank you. Yes, absolutely, and ahead of time. And actually, in our user meeting, which is our Azalea leadership meeting, is focused on ICD-10 this August. So it's a big topic, but we wish everybody the best. I want to mention one more thing about ICD-10. One of the organizations, the AAFP, the American Academy of
Family
Physicians, and the AAPC, which is the Professional Coder Organization. I apologize for that. They do have mappers. They do have search tools on their website to enable coders to look at what the mapping from ICD-9 to ICD-10. websites are out there that you can take your current phase sheet of ICD-9, and they could tell you what all the ICD-10 spin-offs. It's going to be one too many, of course.
Right.
But it is a task, but there are partners out there that can help you through that, and AAPC is one of those organizations that you can access a lot of resources there on their website. But all health IT software providers should have those capabilities built in as well.
All right. Well, during your comments there, mentioned meaningful use and the overall adoption. That was another area that the survey focused on. Respondents came back to the question, what is your status on meeting meaningful use goals? So, overall, testing for stage 1, 31%. Testing for stage 2, 34%. 10% said don't have time or resources to make it a priority. 10% says don't understand what we need to do. And 15% outright said that they're not going to participate going further. So what do you think is going to happen with those that choose not to participate? ICD-10 is related to technology. Technologies continually come up at the top of the conversation. What happens if you don't?
Yeah, I guess I'll just take this from a policy side, and I was there in those early days crafting meaningful use, and I think this is spot on. I believe because meaningful use wasn't written for every single provider out there. It was only written for about 60 to 65%. And that's exactly where your number comes in at 65% here. So it was written for a specific group of specialties and primary care providers, and then certainly some specialties that branch off heavily from family practice in primary care. But so I think this is pretty much in line with what we see. The only thing I would caution about is you're going to see more emphasis on certified EHR. So while you haven't been pushed to participate because the incentives weren't enough, or you just didn't qualify and the incentives weren't for you, and again, that's understandable because that's the way the program was crafted. But you still want to follow it as a framework. So I've done, I do a lot of speaking, and I think one of the biggest things I say to everybody who doesn't want to participate or doesn't qualify for the program is they still use meaningful use as a framework. Still understand how health IT can enable your practice, your practice as a whole, but also your practice of medicine with your patients. Understand, where EHRs can simplify your life and create those efficiencies that we talked about earlier. Understand how technology can assist you with ICD-10 and navigating these new models of care. You brought up this great crosswalk by the professional coders, AAPC. But then also, I think that's fantastic. It's a good resource to point people to. But again, I would push back going, hey, you know what? I would still go look and find, I would look at that crosswalk, but then I also go, if you don't already have the right partner or the most informed partner, is to look for somebody who can help navigate you through that. So
definitely. And I want to address one more thing, that the ones who do not plan into participating. And I have many dear friends who are physicians in this space, and they say, well, the cuts are not significant enough to do that. Well, we're going to find sometimes other users of health IT systems and certified systems, they want to refer back to your office using meaningful use used technology, like direct with messaging and so forth. So yes, you may not lose in cuts, but you're going to lose in patients. And a lot of hospitals also, they're going to be they are forcing their referral physicians to send the referral electronically using the certified product because it'll help them meet their numbers. That's right. So when you think it's just, it's the 2% cuts or 3% is not significant enough, when you start losing 10% of your patients, 20% of your patient, then it become a lot more serious of an issue. So I wouldn't go against the flow in that one.
Yeah, no, and I'll even give you another example to that, because you're 100% right, because you're going to lose patients, you're going to lose referrals, but then also you're not going to be invited to participate in a lot of these new payment models. So over the past 6-7 years, I've created a lot of accountable care networks and ACO structures around the country. And when I go into a community and I set a strategy for this ACO to be created, or this entity to create a value-based medicine or care coordination network, we look for high-performing practices. We didn't find any ever that were performing on paper. We were looking for the practices that understood meaningful use, had high quality measures, could could produce those quality measures electronically and had proof points because they were reporting to databases and so forth, and they did a lot of analytics. That all stemmed, well, in 95% of the cases, stemmed from meaningful use adoption. So, that, and the reason why you want to be part of those accountable care networks, they are the future. But if you could have been a part of them in the last couple of years, or even now, or the next year or so, it gets you ready to where all the payments are shifting in the next 3 to 4 years.
Absolutely. I tell people, and I see it, hospital CEOs and physicians and their office, they used to take care of their patients within the hospital or within their building. Now we're going to have to take care of the patients within our community.
That's right.
And to do that, you have to utilize technology, and you have to utilize, the latest and the greatest.
Interoperability.
Right. Absolutely. That's a great thing. Apparently, we do speak fast, so we're ahead of the time, maybe.
Sure. Well, on the same subject, I actually had a follow-up question related to the proposed changes as stage 3, so it's coming into a little bit clearer view.
Sure.
So how do you think that's going to impact what is available from EHR and health IT by what the government incorporates into stage 3?
Well, one of the things we're seeing in stage 3 that's very obvious is the unbundling of the EHR complete concept. So now it's going to be the use of health IT. And so, for example, there were some specialties that they don't use, for example, e-prescribing. So they were almost getting penalized. How am I going to get my numbers met to meet meaningful use when I actually don't? So now stage 3 going to focus on the use of health IT within your environment, and take those components, and you might want to use multiple products, and that's where we're going to push interoperability. Stage 3 going to be huge on our interoperability. I don't want to get geeky and technical, but we're gonna see EHRs having APIs where they talk to each other more fluent, more, and there's more and more standards in the industry getting introduced to allow that interoperability. Interoperability has been, in the past, always been a challenge. In the last few years, it was marketing campaign. Now it's reality, and I think that's going to be a very obvious thing. What we're going to see in stage 3 is the interoperability and exchanging of data across different health IT systems, and that change is going to open more vendors participating in this. So it's not one vendor providing the full scope. You might have an app that gets certified for that component, and you have another app that does this, and so it's going to be interesting, and it's going to force interoperability.
Yeah, actually, I completely agree, and I think that bodes well for a lot of just highlight on the flexibility that you'll see in stage 3. I want to say there was a lot of rigor and rigidness in stage 1, a little bit in the first version of stage 2. Then we saw, the changes just recently on more flexibility for stage 2. And I think you're seeing more flexibility, to your point, for stage 3. However, the flexibility will only come after you've implemented a lot of the components around EHR use at the point of care with patients, increasing your patient engagement, increasing your interoperability. But then how you execute upon that to go to the next level is going to be more flexibility on the IT and the health IT that you can use. And I agree with the apps and the different modalities. I think a lot of people are asking for that. So they said, hey, we've achieved stage 2. We're doing well, but we need more flexibility in the program. And so you're going to see that flexibility come with stage 3, which is great news.
Yeah, it seems that adoption is going to drive the ultimate goal of what I see a lot of this is to have universal and ubiquitous availability of patient health information to care providers. So it's an evolving world we live in, and hopefully we see that as a culmination of this major initiative. So in closing, we just have a few questions that have come up. We want to thank you for attending Azalea's April at Launch webinar, where we've just discussed the results of the 2015 Rural Health IT Strategy Survey. We do have a few minutes remaining, so I have a few questions that have come in from the field. And if you have any other questions, in addition to those that have already been submitted, please go in.